Good evening, everyone. I think we're maybe a minute early. Welcome back to the Canadian Concussion Center's webinar series, which is sponsored by LIUNA, the Labor's International Union of North America. I hope everyone had a great summer. We're back with our fall webinar series, which will, if you've seen the flyer, it runs from September to December. My name is Leslie Rattan. I'm really pleased to be moderating our series, which was developed for individuals that have sustained concussions, their caregivers, and healthcare providers. And if you haven't been with us before, the sessions focus on various aspects of concussion and include an expert speaker for the first half. And then that's followed by a question and answer period for the rest, where you'll be able to get your questions answered. And our sessions recur every other week on Tuesday evening at 6 p.m. We'd like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. Even as we meet virtually, it's important to recognize the lands we each call home and reaffirm our commitment to improving relationships and understanding with local Indigenous peoples. From coast to coast, we honor the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. Just going back to the series, if you have missed any of our previous previous sessions, they're actually you can find them all on the Canadian Concussion Center website. For this evening's presentation, if you do have any questions, if you just look to the bottom of the screen, you'll see a Q&A as well as a chat button. So if you're having any technical difficulties, please enter those concerns or questions into the chat. If you have any questions for our speaker tonight, if you could please enter those into the Q&A section. As we typically do, we're just going to run a very short poll, and this is really for us to gather information in terms of who is out there watching. I'm just going to wait for Christian to get that up. I will just give you a second there. Okay. So I'm really pleased for this evening's session, pleased to welcome back Dr. Carmela Tartaglia, who is going to be presenting a new talk in the series, Concussion in Older Adults. Dr. Tartaglia is a professor at the University of Toronto and a cognitive behavioral neurologist at the UHN Memory Clinic, where she sees patients with neurodegenerative diseases and persistent symptoms of concussion. She's a scientist at the TAN Center for Research in Neurodegenerative Diseases, where she uses a multimodal approach for biomarker discovery to facilitate early detection of neurodegenerative diseases and diagnosis of persistent symptoms of concussion. The ultimate goal of her research programs is to develop biomarkers for early detection of disease, so as to provide targeted, personalized treatment to her patients. She holds the Marion and Gerald Soloway Chair in Brain Injury and Concussion Research. And with that, I'm going to turn it over to Dr. Tartaglia.
Hi, everybody, and thank you guys for joining on a beautiful evening. So I'm just going to share my slides, and can everybody see them?
Yes, I can see them.
Okay.
Thanks.
All right, great. Thank you. So thank you all for joining, and I'm going to talk to you guys about something a little bit different tonight. And I'm actually not sure how many people this fits the bill for, because unfortunately, sometimes the people that are addressed in this talk sometimes don't recognize the effect of concussions in themselves, and sometimes other people don't recognize it in them either. So I'm going to talk about concussions in the elderly and those with neurodegenerative disease. And so let's talk about what the causes are in the elderly. Okay. Some of the causes are similar to what happens in people who are younger. So falls are a big cause of concussion and even more severe than concussion, like all of TBI. So 8% of those in the above the age of 65 will visit an emergency room because of falls. A quarter of these people actually get hospitalized. And unfortunately, some of these actually fall in the hospital. 10% of all falls end up with a traumatic brain injury. And unfortunately, a history of a single fall is actually a major risk factor for a subsequent fall, which of course would increase your risk of repetitive traumatic brain injury. Motor vehicle accidents are another really large cause of all traumatic brain injury in the elderly. So the 70-year-old and up have a higher accident rate per kilometer driven than any other age group except for young male drivers. This could be due to age-related changes in cognitive functioning, could be changes in vision, cognition, but also psychomotor skills. And unfortunately, suicide or attempted suicide is a really high cause of injury in those above the age of 65, and it's from gunshot or jumping. The risk factors seem to be being a white male with a past history of depression, with some chronic pain, illness, and social isolation. And of course, we can't ignore elder abuse, which is more common than we would like to think, and is a cause of traumatic brain injury in the elderly. And in the elderly, it's actually is important, just like in all people, it is important to think of the mechanism, because when people have falls and they're older, they're more likely to get what we call a subdural hemorrhage. And so that's when you get a bleed in the brain. Whereas if you have a motor vehicle accident, just like with younger people, these will more likely, cause diffuse axonal injury if it's more severe than a concussion. And the distribution of mild, moderate, and severe traumatic brain injury is actually unknown, but the studies suggest that it's similar across all ages. So we don't have any evidence that there's more severe in the elderly. So, when we're thinking about older people and people who may have cognitive impairment, not all, but some, we have to think that, a concussion is a very interesting diagnosis, because a concussion basically needs usually somebody to tell you that something has happened, and then you would, they would report some symptoms afterwards. And you think, okay, this mechanism of injury could have caused this mild traumatic brain injury, and that the person has suffered a concussion, and then afterwards they would have these symptoms. So when you're assessing somebody in the acute phase, you have to think there's got to be a change, right? So there are age-related issues such as variable baseline cognitive function and impaired memory, which could actually make it difficult to know that there's been some change afterwards. If there's not somebody there to tell you that this person at baseline may not even remember that they've had a concussion, may not have remembered the fall that, caused them to be altered afterwards. People have comorbid diseases and take medications that can often affect their mental status. And again, when you're trying to assess the impact, you have to count on the person to tell you that. And of course, there's the interaction of these complex comorbid medical conditions. So, having more than one medical problem, having these medications, having, pre-injury cognitive difficulties, and the aging brain makes it difficult sometimes, and more difficult to diagnose the concussion as well as prognosticate how the person is going to do. And, we worry about, in the younger people, we worry about repetitive injuries. Well, of course, people who are falling are at risk of more falls. And so, with repetitive falls, older individuals are also at risk of repetitive head injury. And in these people, you also have to worry about delayed intracranial bleeding, because many of them are on blood thinners. And the bleed also is more likely to happen because there's been brain shrinkage. Like when you're 30, 40 years old, your brain starts to shrink, and, that's okay. That's, normal aging, and, the alternative is worse. But that does put you at higher risk. And so when we're doing these assessments in the elderly, the lack of guidelines is actually really problematic. And, and this is important for family members of older people, especially if the older person has some cognitive impairment, because when you may not live with them and you visit them, maybe on a weekly basis or biweekly or even every day. And, some days something is off with the person that, you have to think, has something happened to them, and so having no real guidelines on how to assess people, whether they're just older or they have pre-existing dementia, is quite problematic. And, if there's not somebody to tell the doctor or the nurse practitioner who can, make a diagnosis of concussion or a mild traumatic brain injury, if there's nobody there to tell you what the person is usually like, or that they have poor hearing or vision, then it becomes even harder to make these diagnoses. And the in the emergency room, but not in doctor's office usually, but in the emergency room, one of the ways that we test how well or badly somebody is doing is this Glasgow Coma Scale, which is basically trying to see how, impaired your mental status is. And if you don't know somebody's baseline, then it's very difficult to administer the scale. If you don't know that somebody can't hear your instructions, because part of the instructions are, close your eyes and, move your hands and all this kind of stuff. Well, if you don't know that they don't hear, that maybe they don't understand what you're saying, it becomes very difficult to be able to rate how severely injured somebody is. As I mentioned before, one of the reasons that older people seem to be at higher risk is, so the brains on the left are young people's brains, and you see very little black within the brain. So the white circle around is the bone, and the gray stuff inside is the brain. And as you can see, there's much less, black in there. And black is the space between the gray matter of the brain. In the middle, there's these black spaces, and that's normal. But you can see the brains on the left, they're, kind of, taking up most of the space. The brain takes up most of the space. When you look on the right, you can see that brain, especially on the top, you see that there's a lot of black there, right? That space is basically where brain cells have died and is now being taken up by cerebrospinal fluid, by fluid. And so if you have a fall, if something, you get into a car accident, because the brain can move around more, it actually is more likely to bleed. But the other problem is that because there's more space there, it's harder to recognize that there has been a bleed. And when you look below, you can see that, on the left, there's the white of the bone, and right next to it, there's this area. I don't know if you can see that. It's kind of like a light gray, and it's pushing on the brain. Probably here, this person would know right away that there's something going on. In an older person, there would be a lot more blood that would, kind of accumulate before the person would know something is wrong. And so, of course, just the sheer fact that you're older and your brain has changed could be contributing to a higher risk of having a more severe brain injury. So, in the older people, many traumatic brain injuries are actually missed. And many times they're forgotten. A person can have an injury of some sort, but, they don't remember that they had the injury. And so if no family member noticed, then it actually goes unreported. There is sometimes a fear that, their independence will be affected, that they will be forced out of their homes if they report that they've fallen or that something has happened to them. And so sometimes it really is a family members to start to think about, well, why are there unexplained bruises, and why is this person complaining about a headache when they never have headaches before? There's a lot of medications that we give people that are, important for them to take, like, blood pressure medications that, help other diseases. But unfortunately, some of those medications can hurt your memory, or cause your blood pressure to drop too much, or actually make you move more slowly, and that can put you at higher risk of falls also. And, we do know that older adults, they often don't get referred to concussion clinics. I had gone through, 300 referrals, and I noticed there was like less than 1% at the time that were for anybody over the age of 65. Now, when you think about it, it's like, this is the population that has highest risk of falls. I've told you they have motor vehicle accidents. So how come none of them are coming? Are they all ending up with severe brain injury? That's a possibility, but the data doesn't tell us that. So then I looked in over 1,000 referrals, and again, it was less than 1%. But I do have to say that in the last 2 years, that this number is growing. And I think there's been some recognition that older adults are, bringing to it the attention, that older adults are also recognizing that they could be having concussion. And so I'm happy, in an unhappy way, to see that we actually are getting more referrals about this. We actually did a quality improvement project to try to see, so why are there still less, referrals for older people? So we sent out 1,400 surveys to physicians that see older adults or people with neurodegenerative diseases. So these are anybody seeing people with like Alzheimer's or Parkinson's or frontotemporal dementia or Huntington's disease. So, lots of these diseases where people fall. And 141 physicians replied. Most of them were neurologists. And the rest of the group was like geriatrics, there were movement disorders. So people who actually see this older population. And we asked them a bunch of questions. And basically what we found out was that 71% of the responding physicians either never asked or asked in less than 5% of their patients, either they were older or those with neurodegenerative disease, about a history of falls. 51% never ask or don't consider it necessary to ask about concussion symptoms, even if somebody brings to their attention that somebody's had a fall. And, again, less than 4% actually ask about post-concussion symptoms, even if the patient or their caregivers mentioned the fall. So they almost all recognize that concussions can have lasting effects on patients, especially on mood, and they knew about post-concussion symptoms. They did believe that their patients could get better. But, I think it just highlights that there is this problem, that, that older people aren't really being assessed for concussions, and that maybe we're missing out on diseases or symptoms that we could possibly treat, just like in, younger people. So what about, cognitive consequences of traumatic brain injury in older adults? So we all know that younger people who get a concussion, one of the most common complaints are cognitive symptoms. They feel like they can't remember things, they can't concentrate as well. So of course, well, the same can happen in older adults too. So they can complain about cognition, they can have increasing impairment with increasing severity. They can recover, although it is slower compared with younger people. And inconsistently across the literature, we feel that the cognitive outcomes could be worse, but there are studies that show that they can do as well. And of course, their premorbid condition does affect the outcome. So it is important to know their baseline. And of course, if they have pre-existing medical conditions, one can expect that they would have a worse outcome after traumatic brain injury. So a past history of traumatic brain injury is a risk factor for traumatic brain injury. But then if you have cerebrovascular disease or a past stroke, or you have depression, or you're already having trouble with your daily activities, it's a risk for traumatic brain injury, and as well, a risk for a worse outcome. Older adults with traumatic brain injury do have higher morbidity and mortality, slower recovery, and they do tend to have worse functional, cognitive, and psychosocial outcomes. And if they're hospitalized after a traumatic brain injury, and most times people don't get hospitalized if it's mild, So when they get hospitalized, older adults usually require extended hospitalization and usually leave functionally impaired. There was a large trauma registry in 3,244 elderly patients who were aged over the age of 64 with mild traumatic brain injury. And unfortunately, there was a higher percentage of them that did not survive. And there was a sharp increase in mortality from age 65 to 75, but it leveled off at 75. And really, in the older ones, so 75 to 84, it wasn't significantly different from younger people. In those who were over 64 years old, you did have worse functional outcome at discharge. But remember, this is people who actually, these were people who had mild traumatic brain injury, but were bad enough that some of these people actually got admitted to hospital. What about neuropsychiatric symptoms? Well, again, in younger people, we see that the prevalence of psychiatric disorders in post-concussion symptoms are extremely high. Depression up to 61%, anxiety similarly, and the more concussions you have, the higher the risk. And of course, you can have more than one psychiatric disorder. Post-traumatic stress disorder, the symptoms can overlap. You could have comorbid conditions like substance abuse, worsening of premorbid psychiatric conditions. Well, what about in older people? Well, it is actually very common. The most common are depression, anxiety, and irritability. Post-traumatic depression is quite high. So in the older community dwelling, it's from 2 to 9%. In skilled nursing facilities, about 25%. But if you're an older adult with a traumatic brain injury, it's 21 to 37%. And so the issue is that when people have a traumatic brain injury and they're older, they have an increased risk of a new onset depression and, of course, post-traumatic stress disorder. So it is very important to screen for depression after traumatic brain injury. In younger people, we always screen for this because we know that, it's a common problem. Well, the same is true for older adults. And so just like with younger people, the way we treat is we target all the symptoms. So, headache, vertigo, sleep issues, pain. These are common post-concussion symptoms they're common symptoms in older adults, but of course, they're also common post-concussion symptoms. If somebody develops headache, we don't expect people to usually develop headache at 66 years old when they've never had headaches before. And when that happens, a lot of times we think of it as an emergency. But, one of the things that we have to think about, even if the person can't report it, is that, has there been an accident? Has there been a fall? And obstructive sleep apnea is very common in post-concussion symptoms. It's also very common in older adults. So something to think about because, poor sleep will definitely affects younger people, but as well affects older people. Neuropsychiatric symptoms are affected by physical symptoms, so you need to address both of them. And of course, it's important to figure out what happened because, prevention is key. And so if the person had a fall, do they need assessment for what, of course they need an assessment. Why did they fall? What happened to them? Did their pressure, drop? Did they, do they have like poor rugs in their house that they need to, get fixed? So you want to be careful about that. The other thing is the driving because, some older adults shouldn't be driving anymore because they're, maybe they have cognitive issues, maybe they're moving more slowly. And so if they've had a motor vehicle accident and it turns out that it's because of these changes in them, their vision isn't as good, then of course, if you let them go back to driving, they're actually at risk of another injury, which again, sets them up for a poor outcome. So, the interesting thing is in the last few years, there's been a lot of attention that a past history of concussion is associated with neurodegenerative disease. So in 2020, there was a group of researchers who came together to look at what are the modifiable risk factors for dementia. And actually, all brain injury made it to this list. So that means, of course, we all knew that moderate and severe traumatic brain injury would put you at risk of dementia. But it was recognized that, based on large studies, that actually 1 mild traumatic brain injury put you at risk of developing neurodegenerative disease. Now, it's important to remember that, when we think about risk, even saying, a single mild traumatic brain injury increased your risk of dementia by 1.6, though the odds were increased by 1.6. And if you had multiple, you had even higher risk. And this data actually comes from very, very large studies. But, it's important to remember that a risk factor doesn't mean you get automatically, the disease. It just means that it increases your risk. And what was important about this, it was to recognize that, traumatic brain injury, head injury, number 5, actually made it into a list of modifiable risk factors, like lifestyle modifiable risk factors for dementia. And actually, the updated as of now is 14 dementia risk factors, because they've added vision and high cholesterol. And these risks actually increase the risk of dementia by 45%. And so that means that, there's a lot of things that are under our control. And, you say, well, I had the brain injury, so of course I'm at higher risk. But that's one of all of now 14 things. And so, if you had the brain injury, well, you can't take that away because it's already happened. But, you can look at, well, physical inactivity is a risk factor. So maybe you want to mitigate the risk that comes from the head injury by increasing your physical activity so that you can decrease that risk. Smoker, smoking is a risk factor for dementia. You quit smoking, improves your risk. Excessive alcohol consumption is a risk factor. So it's important to recognize that although some of the things, once they've happened, we don't have any control over, we actually have a lot of control over the other factors that are increasing our risk. And so I always tell people, it's like, think of it, you have two baskets. You have the good brain health basket and you have a bad brain health basket. Well, some of the things in the bad health brain basket, I mean, you can't change. Maybe you do have a hearing impairment, right? Maybe you do have diabetes, or maybe you had the brain injury and maybe you even had it when you were a child or a long time ago. But there are a lot of other things that are within our controls, and so that we can fill our good brain health basket to try to mitigate those risks that we cannot control. So physical activity is within our control, quitting smoking, quitting alcohol, making sure that we're social, making sure that we control our weight, making sure that if we're diabetics, we have good sugar control, that we control our blood pressure, that we try to learn new things every day. So there's a lot of things that are actually within our control. And so I think it's really important to remember that concussion happens in older people as well as in dementia. It often goes undiagnosed. It could be associated with a sudden deterioration. So, if you know somebody with Alzheimer's disease, and, these are slow disease of the brain, and they're changed in one day, and, what has happened to them? Could it be that they had a fall? Could it be that they've had some kind of accident? And of course, if they have untreated concussion symptoms, they could also, end up causing behavioral issues. So agitation, aggression. None of us feel very happy when we have a headache, when we feel unwell. And so when somebody has a neurodegenerative disease like Alzheimer's, it could, contribute to their agitation or aggression. And of course, if concussion is not recognized in dementia, in a person with dementia, the problem is it's actually a risk factor for having multiple concussions. And so to summarize, I think it's really important when we move towards personalized medicine, which I think is, our goal is to be able to bring, the medicine to the person, to the, kind of at the single person level, we have to really consider the person and their circumstances and the mechanism of the injury. It's important to remember that, there's special populations when we think of concussion. A lot of times we think of younger people, we think of people playing sports or, motor vehicle accidents, but there's a lot of older people. This is the fastest growing population, in actually many parts of the world, and that there are, certain factors in some of these people that put them at high risk of suffering a brain injury. And of course, some of them are completely normal and have no issues, but age is the biggest risk factor for neurodegenerative diseases, which are, one of the most common diseases on the planet. So of course, there can be some elderly people with pre-existing cognitive impairment. And of course, they can be fearful or embarrassed of reporting or forget to report. And so, they have the same vulnerability for persisting symptoms. And so it is really important to recognize these, and that there's a need to recognize and treat. And thank you for listening. And I'm happy to take any questions.
Great. Thank you so much, Dr. Tartaglia. That was excellent. A really important topic. I am just going to, we've already got some questions. Just a reminder, if you have any questions, please enter those into the Q&A at the bottom of your screen. First question is, how can you tell which cognitive effects or deficits are due to the continuing TBI deficits versus normal aging?
Yeah, that's a great question. And, the fact is that that isn't actually easy to tell. Okay. So, when I was talking about moving towards personalized medicine, we will get in brain diseases to where people are with cancer care, where we are so precise about what is going on with you that, we have what we call like a molecular signature of the cancer. So in the brain, when there's a degenerative disease, so let's say Alzheimer's or Parkinson's disease, there are these abnormal proteins. This is not like a steak building up in your brain, but abnormal proteins that build up in your brain. And those cause certain types of deficits. Well, a lot of those deficits are recognizable because there's a pattern, okay? Then in normal aging, we mostly only accept that people will have, infrequent memory lapses and a decrease in word in fluency or some word finding difficulty. Other than that, we expect most people to be cognitively fairly intact, but there are age-related norms. So, we don't expect you're going to score as well when you are 85 as when you were 55, but you will score like other people of that age group. If you've had a brain injury, it first of all, a lot of people who have concussion, they still score in the normal range. You sometimes, it depends. Like if somebody's got a really bad headache, of course, we'll see, the effect of somebody not being able to concentrate. If they feel unwell, they get very depressed or very anxious. But to say that you have if it's a mild brain injury, a lot of times we don't see significant deficits. And what we see the most is more like distraction. So I think you can tell them apart, and normal aging, most people do very well with normal aging.
Great, thank you. I think this one came in before you discussed it, but I will ask it again. So the question is a history of multiple concussions a predictor of greater risk for dementia?
So I would say not predictor, but multiple concussions are a risk factor. So yes, multiple concussions are a risk factor for all causes of dementia. That means all the neurodegenerative diseases. And repetitive head injuries is the only cause that we know for chronic traumatic encephalopathy. The one that we talk about when we talk about former professional contact sports athletes doesn't happen so much in the regular population, luckily, because these people, it's not just the number of concussions they've had, it's even that repetitive subconcussive blow that we worry about.
Great, thank you. Next question. What happens to those people who get a concussion in their 50s and age into their older years? Are there negative ramifications?
Yeah, most of us who get a concussion, I think it's very rare that somebody has gone through a whole lifetime without having hit their head hard enough that they've actually felt like, oh. So I'm not sure that they would have what you're alluding to, like you're saying, a negative ramification. Now, that being said, let's say somebody has a concussion in their 50s and they continue to have, post-concussion neuropsychiatric symptoms that are not well treated. Well, neuropsychiatric symptoms cause cognitive impairment. And so in that case, it does have negative ramifications. So it's almost like the consequence of the concussion, especially when not treated, can have negative ramification. I would say if you can treat the concussion symptoms, I'm not sure that we would say, well, we see the negative ramification for the majority of the people.
Great. Okay, thank you. Um, Next question. Are the 12 dementia risk factors listed in order of importance?
No, actually, they're not. There's a great paper, and now a new paper that's come out, and it's the Commission 2024, and maybe I'll make it available to Christian, and people can look at it, which basically looked across a person's lifetime, because actually those risk factors are across a life, and what percentage do they contribute? So each one that I talked about, maybe has a 3% influence or 4% influence, and it's when it happened, so it's 3% from when it happened and you were a child, versus another risk factor that is more evident when you're in midlife versus in late life. So they're not in order, but they do ascribe a contributing percentage to the risk of dementia.
Great, thank you. Next person is asking, are there any treatments for daily post-concussion headaches that are more effective for an older person?
Yeah, that's a great question. And we actually don't know because, it's not like we've done trials in that. And, you might know that a lot of trials, they exclude older people. So it's not easy to think about that, like in a scientific evidence-based way, the way we would like to do it. But things to think about is, so headache prevention medications can have side effects, as anything. And, you want to choose, like, one of the ones that we use very commonly in younger people is what we call an anticholinergic. So it's something that works against the acetylcholine system. And acetylcholine is something that goes down with age. And if it goes down, you could have some memory problems. So that would not be a drug I would like to use in older people. There's another one that can give people word finding difficulty. Works really well, but it gives people word finding difficulty. So I've already said, well, actually, that's the one thing older people do complain about. So again, good drug, but it has this side effect that might be very irritating to an older person who already has some word finding. So I don't have a best one, but it's, really like you try to tailor it to take into consideration that person's particular situation. There's one that's a blood pressure medication. So older people, some of them have a high blood pressure. And so you think, oh, maybe that would be a good one, kill two birds with one stone, kill the birds, actually. But at the same time, some older people, their blood pressure is too low. So yeah, we really try to take a targeted, personalized approach.
Right. Okay. Thank you. If someone has a hearing impairment and gets hearing aids, does that still count as a risk factor or does that help to mitigate?
It's mitigated. it's uh, fantastic to do that because that's the whole point. You can counteract some hearing impairment by getting hearing aids.
Perfect. Thank you. Okay, next one. Not related to sustaining a TBI as a senior, but wondering about the effect of TBI and persistent symptoms when sustained at around 50 years. Do the post-concussive symptoms change as we age? And then there's a comment, the American Brain Injury Association will include a TBI as a chronic health condition as of January 2025. Any movement toward that here?
Yeah, I think there is some recognition that traumatic brain injury. I know there's a bill that's being put forth, and there's support for this bill to that TBI should be considered a chronic health condition. I think it's more around moderate or severe TBI, which of course is a chronic health condition. So yes, I think there is some movement here, but not as much as we would like. And in terms of the symptoms changing or with age, it's an interesting question, and we're going to try to look at that because I have to say that a lot of the older people that I've seen in my clinic with concussion, they get better faster than some of the younger people. And, they're reporting slightly different symptoms. And so I don't know. I think that's a great question and it deserves to be studied. And I'm interested in looking at it. So hopefully the next time I present on this topic, I'll have a better answer for you.
Yeah, really interesting. Thank you. How do you know when word finding is part of normal aging versus related to possible injury or dementia?
Yeah, so when we think of word finding, so as a cognitive neurologist, which is what I do, and when we think of it as a cause of dementia, we think of it as a progressive problem in fluency or in comprehension, but mostly word finding would be in fluency, and it's progressive. So, when I'm talking about word finding in aging is, every now and then you can't find a word. In a degenerative disease like a primary progressive aphasia, within a few years, people have lost many, many words. They can clearly see that they're losing words and their family members are noticing. So, mild, stable word finding difficulty, we think is just a sign of aging. A progressive condition where people are, yearly losing more and more of their vocabulary, and, some people end up mute. That's a different condition. And is quite different from normal aging.
Okay, thank you. Is there a blood test for TBI like there is to diagnose a heart attack after the fact?
Yeah, that's an excellent question, and there's a lot of work being done in that. But as of now, we have tests that can tell you when you have something more severe. So, like a moderate or severe TBI, yes, there are some tests. They aren't of clinical grade yet. So, clinical grade means, like when you want to check your thyroid function, you go to your doctor, they order a blood test, you go to the lab and you get it done. That we don't have yet, but we have some good markers that you've had a more severe brain injury. But the problem is for concussion or mild traumatic brain injury, we're still struggling there. We don't have anything that's great.
Right. Okay, thank you. Is there any such thing as a non-traumatic brain injury?
Well, I don't know about non-traumatic. I mean, there are, yes, there are. Sorry. So if you mean things like hypoxic injury, infectious injury, inflammatory injury, yes, there are all kinds of non-traumatic brain injuries.
Right, thank you. Um, the next one is percentage of PCS patients with sleep difficulties who can benefit from obstructive sleep apnea therapy. I
Yeah,
guess
that's a
maybe if you
very,
can comment on that.
yeah, it's so, I mean, that's hard to know, right? Because that would mean we'd have to, just at large sample like 100 or 200 patients who've had a concussion and send them for, a sleep study. I'll tell you one thing. So what we did was a few years ago, we did a retrospective study just showing, how many people we'd sent for a sleep test, a sleep study, and had come back with obstructive sleep apnea. And the numbers were very high. And what was interesting was like a lot of them didn't even have the typical phenotype. So when we think of people who you might worry about is, okay, they snore, they wake up feeling tired, they may have a headache, they have big necks, they're usually men, they're slightly overweight. But there were people who did not fit that phenotype, and a good number of them. And so we found like pretty high numbers, like in the 70s, that ended up with a positive sleep study. So I have to say that I am quite lenient to tell people to go get a sleep study as much as, as like if they'll go, because actually sometimes patients don't want to go. I understand, or they have sleep apnea, but they don't want to wear a CPAP. And I agree that, we put people on the moon. We should come up with something better than this mask that, looks very uncomfortable. But at the end of the day, it's very important for your brain to sleep properly. Like we now know that when you sleep, that's when you're clearing the amyloid from your brain. That's one of the bad proteins that builds up in Alzheimer's, but probably in the other neurodegenerative disease. So your brain has to sleep. And even though you think you're asleep, if you have sleep apnea, your brain is not asleep. It could be waking up like hundreds of times an hour. So that's very bad. It also causes damage to blood vessels in our brain when we have this sleep apnea that isn't treated. So it's very important. And I know some people struggle. Those masks are very difficult for some facial conformations. So I agree, we have to improve, but it's very important to think about sleep apnea because it's very common, and to treat it if it's there, because it can have devastating effects on your brain, as well as contribute to poor cognitive function. So it gives you concentration problems, it gives you memory problems. It's important to treat it.
Yeah, absolutely. When do you know if you need to have imaging if you've had a concussion? What if someone's having consistent headaches? Is that an indication?
Yeah, I mean, headaches happens in like almost 100% of people with concussion. So in that case, we would image everybody. And I have to say that, I would do a lot of MRIs in the, maybe in the first 5, 6 years that I started. And, I would say I can count on one hand how many times there was something abnormal. And I'll tell you that most of the time it was what we call an incidentaloma. It was not related to concussion. So I'm less, and since COVID, as everybody knows, the MRI wait times have gone up. So, it used to be we order an MRI, and by the time the person had it done, they weren't even a patient in my clinic anymore because they were completely recovered. So I've started doing it less. Now, I use criteria, and of course, it's all individualized. It's, if somebody's had many concussions in their lives, have symptoms that have been ongoing for a few years, and there's no reason, like they don't have like untreated depression or anxiety, and, they start to have cognitive impairment. Especially if they're older, I do send them for an MRI. But I don't do it routinely for everybody anymore. Just right now, I don't think our system can sustain it.
Absolutely. Okay. I had a concussion after falling on a slippery floor a few years ago at age 70. Recently, the dizziness and head pain that occurred after my concussion returned after having a neck massage. Is this related?
That is very unusual, and I would have that investigated. Because usually we don't see relapse of concussion symptoms. And of course, so hopefully when you say massage, you're not talking about cracking of your neck, because that is different, right? Then we worry about other things. But it's unusual to have a relapse after you say your concussion got better.
hmm
Yeah.
Okay. With the shortages of healthcare providers in our public system, MDs and RN practitioners, how realistic is true personalized medicine for seniors when ageism can also play a role? so many seniors already do not have a family doctor.
Yeah, I agree. It's a big issue. I'm,
Mhm.
I'm a cognitive neurologist. I see people with neurodegenerative diseases as well as concussion, and I end up being people's family doctors, which of course, you shouldn't want me as your family doctor. It's I know there's a shortage, and we have to address that, and I think there has to be an overhaul of our system, and I think it's going to take some creative solutions, but I don't think it's because we don't have the money. I think that the money is not being directed to the right places. I do truly believe that prevention is very, very important. Prevention, when people have a concussion, preventing it from becoming chronic symptoms by treating it early on instead of leaving people to languish for months, waiting around for proper treatment. Promoting, healthy brain living. It's like there's a lot of things that we know that if your blood pressure is not well controlled, if you're living a sedentary lifestyle, if you're letting your diabetes be out of control, this puts you at risk of diseases. So I do think that we have to change the way we approach health and healthcare. And I do think that the means are there. And, I think we can have a great system. But probably it's going to take leaders who think a little bit differently about where to put money, because we live in a system that is very reactive and waits till people get very ill, and sometimes to save pennies. Like I'm a person who deals with dementia care, and I have people who end up in crisis in our emergency rooms because they can't get an extra few hours of PSWs. So that's, in
Mm.
my mind, wow, you saved yourself a few pennies and it's costing the system thousands and thousands of dollars. So yeah, don't don't think that's well placed, uh, resources.
Yeah, great. Thank you. You mentioned vision. I think we're talking about the dementia risk factors. Are you talking about visual ocular motor changes as a risk factor?
No, I was talking more about some of the visual vision changes that occur in the elderly. So, they're at higher risk of macular degeneration, retinal detachments, cataracts, glaucoma. I was talking about those kinds of things, not the ocular motor changes that occur after a concussion, that, for the most part do resolve with time.
Okay, great. Is the prognosis impacted by multiple head impacts within the same concussive incident? I guess if you're in
Yeah.
an accident and you're hit several
Yeah,
times.
I think that's a really important question, and I've always wondered about that. Like when people get hit and then they fall to the ground. So technically, they
Mhm.
suffered two hits. I actually think that's very important, and we should be paying closer attention to that. Like we count a concussion as this one event, but of course, if that one event included multiple blows, well, why would it be only, that's not just one concussion. That means your brain was hit multiple times. So I think that's actually a very important question that we need to study more.
Great, thank you. Could you please list some of the neuropsychiatric treatments for TBI?
Yeah, so neuropsychiatric symptoms are very common after traumatic brain injury. So things like depression, anxiety, post-traumatic stress disorder, nightmares, those kinds of things are very common. And we treat them like they do in psychiatry. So for depression, first-line therapies are usually selective serotonin reuptake inhibitors, so SSRIs. We can use for anxiety, same thing. We use a lot of we use mostly these antidepressants. There are some neuroleptics that we use. There's, these off-label drugs that we use for also, but most of the arsenal comes from psychiatry. It's not like we have special therapies that are for a post-concussion, neuropsychiatric symptoms. We use what has been shown to work in psychiatry.
Great, thank you. Is cognitive rehab helpful in seniors post-concussion?
Yeah, I think why not? I think it can be very helpful. I think the thing that you want to remember is that cognitive rehab includes a learning aspect, right? So you have to be sure that the person who is undergoing that kind of therapy has the ability to learn it, just like anybody else, right? And so as long as the person doesn't have significant cognitive impairment, can learn the techniques, I think it could be as beneficial.
Great, thank you. Is there a protocol for removing an older person from their home if they've experienced multiple falls and TBIs? What happens if the person lives alone and has no family at all? Are they taken to a specialized facility?
Yeah, that's a great question and actually not easy to treat, to deal with because there actually aren't any protocols. Like somebody has to intervene, somebody has to bring it to somebody's attention. A lot of times, though, like let's say one of the falls lands the person in the hospital, then when the discharge assessment is done, it a lot of times it would include maybe an assessment of their cognition, their assessment of their functional, like their function outside, like being able to, pay their rent, put food on their table, all that kind of stuff gets assessed. And so if they can't do that, then there would be a protocol put into, implemented, which would find that person an alternate level of living. The the issue is that it has to be brought to somebody's attention, right? If you're having repeated falls in your
Mhm.
home and nobody tells anybody, then I mean, nothing will happen, especially if you don't have family or friends coming by to check up on you and see, make sure that you're okay. Yeah, that's a hard one.
Yeah, yeah, it definitely is. I was diagnosed many years ago after a sleep study with idiopathic hypersomnolence and have now had post-concussion symptoms, especially headaches, for the past 6 years. Could these be related?
Yeah, I don't know, but I think if you should have another sleep study done and see whether these are, whether this has exacerbated something that you already had, or you have something new on top of that. Because I don't know about hypersomnolence, whether that was associated with headaches already. And so that's where they're coming from, and it's just got worse. People who have a past history of headache who get concussion, they can have a worse outcome with respect to their headaches and treatment of their headaches. But if many years have passed between your sleep studies, you should probably get another one and see if you don't have some other sleep issue.
Great, thank you. How can it be determined if an older person with TBI is okay to resume driving again?
Yeah, so, I mean, we do cognitive assessments and see how people are doing. Of course, a neurological exam gets done. And then if there's some concern after that, then we usually send people for driving assessments. And unfortunately, they're quite expensive. They're $650, $700. There's only a few of them that are recognized by the Ministry of Transportation. But in the end, that is what is in the best interest of the person and their family, because although the doctors, nurse practitioners, the people who report could get in trouble for not reporting somebody, but if you're deemed to not have been able to drive, your insurance company could, refuse to cover you. And then you're left liable for, damages if like you ended up, hurting somebody or destroying somebody else's car or something. So I think it's in everybody's best interest to make sure that the people driving are good drivers, and so there are driving assessors that can do that because they take you on the road, right? It's not like a
Mhm.
pencil and paper test or a digital test. It's on the road test.
Great, thank you. Just watching the time. How does one get assessed on their type of concussion, knowing there are many types?
Well, I don't know, I hear a lot of different types of concussion. I'm not sure that I understand what that means. I don't even have a marker for any concussion right now. So I can say that, the symptoms that come about after a concussion are quite varied. But I don't know that we have profiles done so that, one type of symptom profile or constellation is associated with a different type of concussion. Some people do say, I hear sometimes I get referrals say complex concussion or severe concussion. I actually don't know what those things mean. So maybe somebody could send me something to illuminate me.
Okay, thanks. Okay, one more question. I think what they're asking, what blood test markers found to determine moderate to severe TBI are not found in mild TBI or concussion?
The one is called, I think it's UCHL one. I think that was the one that had FDA approval. I'm not sure it's used anywhere routinely, but it was shown to be associated with more severe concussion. I don't use it in my practice because I don't see moderate or severe brain injury even in research. But I think it's called, it was like a ubiquitin marker. I think it's like UCHLH or something like that.
Okay, okay, great. All right, well, I think we are right at 7 o'clock. So thank you so much, Dr. Tartaglia. That was an excellent presentation, and I think we covered a lot of information in the Q&A. Just a reminder to everyone watching, there will be a short survey coming your way. So we really appreciate it if you can take a minute or two just to complete that. And we're always welcome to feedback and suggestions. If you had a question that wasn't answered, you can also include it there. If you do that though, and you want us to get back to you, please just include your email because the surveys are anonymous. And just to let you know, our next session is going to be in 2 weeks, September 24th, and we are going to have Dr. Charles Tatter with us, and he is going to be presenting another new talk, treatment of post-concussion symptoms related to screens at work, school, and play. So thank you everyone for attending and have a great evening.